Good afternoon. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Welcome to today's webinar, Joint Replacements, What You Need to Know, presented in collaboration with Friends Health Connection. Each year, 600,000 people in the United States have knee replacement surgery. About 90% of those who have the surgery report significantly reduced knee pain, according to the American Academy of Orthopedic Surgeons, and are able to resume their normal activities with greater mobility. During today's webinar, we will learn more about knee replacement surgery from Dr. David Aberton, an orthopedic surgeon at Robert Wood Johnson University Hospital, Somerset. We will begin today's webinar with 20 minutes of a moderated discussion, followed by questions from our audience. So once again, thank you all for joining us, and thank you, Dr. Aberton, as well. So let's first start off, Dr. Aberton, with you maybe telling the audience a little bit about yourself.
Sure. Well, welcome to the seminar. Sorry for the technical difficulty, but my name is David Aberton. I'm an orthopedic surgeon with Summit Medical Group. My fellowship is in sports medicine, and my practice is primarily exclusively shoulder and knee surgery. I do total shoulders and total knees. I do approximately 250 joints a year. I do them at Robert Wood Johnson Somerset here. I implemented and championed the Joint Surgery Center, which is a key component to our joint replacement program at Robert Wood Johnson. My office is in Bridgewater and Warren, and that's
pretty much it.
Pretty much it.
Well, thank you for sharing. We always appreciate that and really want to just really get to know our speaker before we dive into it. So let's talk about knee, an overview of the knee joint, how the knee works and its physical structure to start.
So basically the knee, when we think about the knee or talk about it, there's three parts to the knee. There's the inside part or medial side of your knee. There's the lateral side or outside part of your knee. And then there's where your kneecap meets the femur. And with respect to arthritis, one or all three of those compartments can be affected. But in general, the knee joint is made up of your femur and your tibia or shin bone. And it allows you to bend and extend your knee. There's rotational component and side-to-side movement. And that's supported by ligaments on the side and the center of your knee, as well as tendons around the front and the back of your knee.
So then what might be some common causes of knee pain?
Generally, I would classify knee pain into three categories. One is overuse, so we see that more in the sports, younger population. There's traumatic causes of knee pain, so ligament injuries, bone contusions, fractures. And then there's the wear and tear, which will be the focus of this talk in terms of arthritis and other conditions.
Okay, so arthritis. So let's talk about osteoarthritis. What is it, and who is most at risk for developing osteoarthritis?
So osteoarthritis is essentially the wear and tear of the joint. And what I like to tell patients is, I think the best analogy is think of your knee like a road. And so lining the end of the femur and the tibia is the road or cartilage. And then beneath the road is bone or dirt. And so normally our joints don't hurt us because the road or cartilage doesn't have any nerve fibers in it, but the bone or dirt does. And what arthritis literally is visually, if you ever saw it in the operating room, it's a progression of softening of the road, fraying of the road, cracks in the road, bigger cracks in the road. Eventually you get potholes in the road, and at some point you wear out the road completely. And while that's happening, the bone or dirt starts to feel more pressure, which can cause pain. In terms of getting it, it really runs the gamut from people with prior injuries are at risk for getting it. There is a hereditary component. So sometimes you have patients who've never played a sport in their life, they never had an injury, and they get it in their 60s, 70s, 80s. weight is a factor, not in so much in terms of getting arthritis, but it contributes to the pain of arthritis. So it's hard to predict who it's going to be in. And people often ask me, you know, if I have it in my left knee, does it mean I'll get it in my right knee? And it's not necessarily the case. You could have it just in one knee joint. But ultimately, at the end of the day, and we'll talk more about it, is we treat your symptoms, not your x-ray. So you could have arthritis by x-ray, but at the end of the day, we care about how much pain you have.
Okay, thank you for that explanation. So then what are maybe some common treatment options for osteoarthritis?
In terms of treatment, you know, the primary focus is on non-operative treatment. And then certainly there are joint replacements and other procedures you can do, but the goal is to try and minimize your pain for as long as possible. Unfortunately, there is no cure for arthritis, so everything we do is more or less a Band-Aid. And the goal is, you know, like I said, is to minimize your pain for as long as possible. The best treatment in most cases is a combination of education, understanding what the problem is, what the triggers are. Activity modification is important. So depending on your lifestyle, certain exercise doesn't cause arthritis, but it can exacerbate or irritate your symptoms. So we may have to talk about non-impact exercise, such as riding a bike, elliptical machines, swimming. Physical therapy can be helpful because sometimes there's tightness or weakness around the lower limb with respect to your pelvis, quadriceps, hamstrings, so they could focus on stretching and that could help relieve your pain. Anti-inflammatories certainly can help. A lot of people always ask me about supplements, and certainly if you go on the internet or go to any GNC, they'll sell you lots of supplements which may or may not work and are controversial, and I'm sure there will be questions about that. And then there are injections, and generally the two main injections are cortisone or steroid injections, which are very effective for minimizing pain. There's something called hyaluronic acid, which is a protein that normally is in your joint fluid. And as you get arthritis, the concentration of hyaluronic acid decreases. So this acts like a lubricant or WD-40. Some people call them gel shots, and we could talk about the efficacy of that. And then more recently, there are other injections such as PRP or platelet-rich plasma, stem cells. Those are sexy in the orthopedic realm, and there's certainly no downside to them, but the scientific evidence isn't conclusive, and there's no real long-term data, but that's something that we talk about a lot with patients. And then ultimately there's surgery, and there's different kinds of surgery ranging from arthroscopic surgery, depending on for more mild, potentially arthritis. There's something called a tibial osteotomy, which is rarely indicated, but more for younger people. And then there's partial knee replacements and full knee replacements.
So out of all those treatment options you mentioned, what is the most common treatments that are used?
Well, certainly the most common is physical therapy, anti-inflammatories, if they're tolerated. I mean, in my practice, I definitely encourage people to focus on weight loss and activity modification. And then I would say for most people, before they have their knee replaced, they'll try at least one type of injection, most commonly cortisone. I would say a lot of people try the lubricating or hyaluronic acid injections as well. And then ultimately, when patients cry uncle, then we contemplate knee replacement surgery.
Okay, so when should somebody consider a knee replacement surgery?
I mean, ultimately, the main driver to consider it is pain after you failed everything else. So certainly once you've tried all the things we've just briefly outlined, and it's significantly affecting your quality of life, activities of daily living, you're avoiding doing things because you're in pain or afraid you're going to be in pain, that's certainly when you should consider a knee replacement. I will never tell a patient they need a knee replacement. Patients always tell me they want one, and generally the reason to want one is for pain. Another consideration is range of motion. So what can happen as arthritis becomes more severe, you could actually lose motion in your knee, whether it be you can't fully straighten it, or some people can't bend it as far as they can on the other side. That becomes a factor because while the primary goal of joint replacement surgery is pain relief, the secondary goal is range of motion, and the best predictor of your range of motion after surgery is what was your range of motion before surgery. So someone who comes in with significant stiffness is not the same patient with arthritis who has no stiffness. So that's a secondary consideration.
Okay, so let's say somebody is at that point where, you know, they're ready for a joint replacement surgery or a knee replacement surgery. Can you tell us what a patient can expect when they come to Robert Wood Johnson University Hospital, Somerset, for a knee replacement surgery?
Absolutely. So, you know, obviously most things start in the office with the surgeon, whether it be me, myself, or one of the other surgeons at the hospital. And generally, once we get a date scheduled, you'll be set up with a for our joint seminar, which is a class you take prior to the surgery, where you get a tour of the hospital, and then you learn about what to expect the day of the surgery while you're in the hospital, and follow up. So the more you know, the less fears you have. We also give every patient a book that has filled with useful information about preoperative planning, again, while you're in the hospital afterwards, and that's provided once you sign up for surgery. Other things to expect is you will need to see your medical doctor or any other specialists like cardiologist, pulmonologist, depending on your medical history. Depending on whether you have diabetes or not, we try and optimize patients in terms of a nutritional point of view. For diabetics, your hemoglobin A1C, which is a marker of how well controlled you are, needs to be below 8. We also get blood work to check your blood level to make sure that's not low. Some physicians will make you go to a dentist as well to make sure you don't have any abscess cavities in your teeth. And then at the same time that you take this class at the hospital, that's when they'll do all your blood work, EKG, lab testing. And then we usually see you back the week leading into the surgery. We go over everything in detail, answer any questions the patients have, fill out a bunch of paperwork, and then we do it. In my practice, in my hands, I do the surgeries on a Tuesday. Most of my patients stay overnight, and then they go home on Wednesday. We get a nurse therapist to come to the house for the first week or 10 days, and then you will do outpatient therapy.
Okay, so maybe if you could explain what happens during the surgery. You may not go into too graphic of an explanation, but if you could maybe share with the audience.
Certainly. So again, for us, in terms of pain management, we have a multimodal approach to pain. And so you take Tylenol the day of the surgery. Our anesthesiologist will typically do what's called a nerve block. So under ultrasound, and you're sedated for it. They put a catheter in your upper thigh groin area, so that helps decrease your need for pain medicine. We typically do it under spinal anesthesia in most patients. Sometimes if we can't do the spinal anesthesia, they'll do general anesthesia. And then in terms of the surgery, we don't cut out your knee. Think of it more of like putting a cap on a tooth. So we make a few centimeter incision in the front of your knee. It's a straight vertical line. Depending on the surgeon, they either go through your quadriceps tendon or through the muscle, which is what I do. And so it's like a quadricep sparing approach. And then we literally are removing the ends of the bone or the road, as I gave the analogy, and we're putting a metal cap on the end of the femur and the top of the tibia, and there's plastic in between. And then we also put a little bit of plastic button behind your patella or kneecap, so that resurfaces the kneecap as well.
Okay, well, thank you. That was very interesting. So what are the risks of having knee surgery, replacement surgery? Are there any risks?
Of course, with all surgery, there's risks. There is a risk of infection, which is small. There is a risk of persistent pain or stiffness. again, usually the biggest predictor of stiffness is the motion prior. A small percentage of patients continue to have pain despite a well-done knee replacement surgery. There is a risk of a blood clot in your calf, which can go to your lungs. The best prevention for that is moving around. Typically, we'll put patients on some type of blood thinner, aspirin, or something stronger, depending upon the history. There's a small risk of heart attack, pneumonia. When you cut the ends of the bones bleed. There's a very small risk, like less than 1% risk of needing a blood transfusion, which is very rare. Depending on your age, and I'm sure we'll talk about this, knee replacements don't last forever, so there is a risk of needing more surgery in your lifetime, but generally they last 20, 25 years. There's very small risk of fracture, which is very rare as well. But all these risks are very small.
All right. Well, and thank you. So I guess, what is the recommendation? Do you recommend or can somebody have both knees done at the same time if needed, or do you recommend one and then the other?
Yeah, so frequently patients will have bilateral knee arthritis, and if they have pain, similarly in both knees, it is reasonable to do both at the same time. Generally, we have a candid conversation about it. It's generally best done in people under the age of 70 with no medical problems, so non-smoker, non-diabetic, no heart disease. The advantage of doing both at the same time is once you're done, and there's no looking back. So when you recover 3 months, 6 months down the road, you don't have to think about doing your other knee. The disadvantage is there is a slightly higher complication rate because you're doing twice as much surgery, so there's more blood loss. You're not going to be moving as well, so higher risk of blood clot, but it's not significantly higher, but it is a little higher. And then in terms of just function, pain, recovery, it is more painful and more difficult in the first 6 weeks after doing both at the same time versus one at a time. So as long as you're motivated and you qualify from a risk stratification point of view, it is reasonable to do both. I do both, but it's a conversation I have with the patients. So some patients, want to do both if they have arthritis in both knees. Others, their one knee isn't as bad as the other, so we'll do the worst one first, and then 3 months later we'll do the other one.
So when somebody does have a surgery, how long does that patient have to stay in the hospital, following that surgery?
Right. So typically our length of stay is a little over 1 day. So that means some patients stay 2 days, some people stay less. I again, in my practice, most of my patients leave the day after surgery. So I do them on a Tuesday. Patients go home on Wednesday. There are some patients that would qualify for what we call same day surgery, where they literally go home later that day. That's becoming more and more accepted and manageable from pain management point of view, functioning point of view, and just culturally, as the hospital can handle that better in terms of what's required. But generally, patients stay overnight.
Okay, and that's regardless of whether it's one knee or two?
Well, we don't, there's no hard and fast rules in the sense that we do what's best, safest for the patient. So I would say my bilateral patients are more likely to need another day of recovery. But I would say about half of them go home the next day, just like a single knee. So it really just depends on the patient, how they're doing. It becomes a safety issue in the sense that we'd rather keep you another day because it's better for you to go home with a nurse therapist at the house than going to rehab. So as long as you can do stairs and you're cleared by physical therapy and your blood level's good, your blood pressure, all the other things that we look at are good, you can go home. But it's not like it's the next day you have to leave. It just it works out that way mostly.
Yeah. So, okay, so after surgery, and you mentioned talking about recovery period. So how long is the recovery period after a surgery?
It's a great question, and it's everything I say is generalized, because I always joke, once you've managed one person's pain, you manage one person's pain. So everyone's different in terms. Some patients have no pain and are doing great at 1 week. Other patients, it takes 6-8 weeks or longer. But in general, you're up and moving right away with a cane, eventually a walker. For a right knee, you're usually driving by 4 weeks. 2 weeks is optimistic, but 4 weeks is realistic. And I would generally say that by 4 to 6 weeks, you're independent, taking care of yourself, almost living your life. In terms of work, it really depends on what kind of job you have, what the requirements are physically. So if you have a desk job, obviously that's a different conversation than if you're a physical laborer. And then I would say by 3 to 6 months, you're happy you did it and you're functioning at a pretty high level. But it does take probably closer to 9 months to a year till you forget about your knee in terms of range of motion, everything.
So along the lines, something you mentioned when it came to work, are there any limitations following knee replacement surgery? So I know that mentioned it, work depends on what you do, but are there any other limitations with the surgery?
So limitations, I mean, from a sport point of view, most patients, depending on your age, are looking to get back to, recreational type activities. So gentle skiing, cross-country skiing, doubles tennis, golf, riding a bike, elliptical machine, paddleball. All those things are reasonable. I would say long distance running, probably not recommended. Anything where you're at high risk for falling also would not be highly recommended, but that doesn't mean everyone listens to me. And then in terms of work, I would say the biggest challenge after knee replacement surgery is kneeling. So we let you kneel on it, but about half the patients are uncomfortable kneeling on it. So from a work point of view, if you're a laborer, electrician, if you're on your knees a lot, you might need an extra pad or a cushion, but there's no restriction in the sense you can't do it. It's just, it can be uncomfortable to do it. I don't see any profession that I see frequently in my practice that I would say you can't go back to work. It's just, whether your pain allows you to.
So then, can these replacements or these artificial knees wear out over time?
Yes, they can. And there's really, when we talk about that, the technology has gotten and the implants have gotten pretty sophisticated, but there's two basic ways knees wear out. So historically, the plastic liner between the metal caps could wear out, although those have become very durable and long lasting. But that's one way a knee can wear out. The other is where the metal cap meets the femur. Usually that's either cemented in, or in younger, better bone, it can be what's called press fit in. And if the junction where the cement and the metal meet the bone, if that can loosen over time, and so think of it like a cap on your tooth. If it gets loose, it doesn't fall out like a cap on your tooth, but if it gets loose, it can be painful. So changing just the plastic liner is pretty simple, straightforward. Obviously, if you have to take out the metal cap on one or both sides, that's where it can be done, but it becomes more involved than doing a knee on a virgin knee. But generally, if you do 100 knee replacements today, in 20 years, 85 of them are still going strong, doing well. So it's always a statistical question and answer in terms of, can they wear out? Yes. Can I predict who it's going to wear out? No. So that's where statistically they last a long time. And so for the majority of people, if you're getting it done in your 60s, 70s, it should last your lifetime.
So you mentioned, a 20-year time period is, in general, on average, that how long a joint replacement would last? Is there a time frame in which it would start wearing down again?
So again, statistically, they last, 85% of the time they last 20, 25 years.
Okay. Okay. Just wanted to, see if there was an average, but thank you for that. So now, again, we always like to talk about prevention. So what are some general tips that for people of what they can do of all ages to keep their knees healthy?
Well, yeah, it's a great question. I mean, the best prevention is don't get injured because, once you have an injury to your knee, that increases your risk, but you could figure out how to do that, let me know. But in general, your knee likes motion. It doesn't like impact. So for most people, moving is good. And certainly keeping your weight down is good for your joints, but obviously for your body. And that's a double-edged sword because a lot of times people tell me they can't lose weight because they can't work out because of their arthritis. But in general, there is no true prevention. But moving, keeping your joints healthy, moving, eating a clean, diet. There's lots out there, but I would say avoiding sugar in general, processed foods, those can cause inflammation. And then non-impact exercise such as riding a bike, elliptical machine, those are easier on your knee.
Yeah. Would you recommend like a aquasize or water type of an exercise for?
I think water aerobics is great. I mean, certainly once you have arthritis, those types of exercise are ideal. I'm not suggesting that running causes arthritis, but when you have arthritis, running is going to be harder on your knee and will more likely cause pain from the arthritis. The reality is once you have arthritis, whether you sit at home and sip tea or live your life and stay active, your arthritis can progress to the point where it can cause pain. So, as I said earlier, the goal is to minimize your pain for as long as possible, at the same time keeping you as active as possible. So we don't want you doing nothing. We want you staying active within reason, but it's just a matter of managing the pain.
Okay. Thank you so much. Well, at this time, I want to give our audience an opportunity to ask you some questions. So if you do have a question for Dr. Aberton, please post it in the Q&A section of our webinar. And I can see we already have a few. So this is kind of a situational type of a question. So I think here, this individual has had a motorcycle accident or injury to the right knee 50 years ago, tearing the ACL and the LCL. 3 years after the accident, cartilage was removed. Again, they are able to do, pretty much anything, run marathons, I guess with very little pain due to strong quads, they feel. About 5 years ago, they received 3 monovisic injections. I guess that's is that a steroid or?
That's the hyaluronic acid or gel shots.
Okay, thank you for clarifying that. And then 3 years ago, they were told no more, as they were, I guess, bone to bone, and there would be no benefit. So went for another opinion, got an injection, and got opposite opinions. So, and I guess wanting your opinion, around, they're almost pain-free. So, I guess if you can maybe elaborate on that, I guess that's something where they would probably have to schedule an appointment with you, really, right?
Yeah, but essentially,
it's hard for you to answer that.
I'm not sure what the question was, but
yeah.
But in general, that's where we treat patients, not x-rays. So from what you're describing is someone who had an injury 50 years ago, now they have arthritis, they were doing well with injections, they see a doctor who says, you're bone on bone, we can't help you. But the reality is, as long as the injections are working, my opinion is you continue doing that as long as you have good quality of life and the injections are lasting. You know, for the gel shots, we want them to last 6 months or longer. So as long as it's working, you could get an injection every 6 months, even if you're bone on bone. So there's no time limit. And I have patients who have terrible looking x-rays. It hurts to look at their knee, you know, and they tell me their pain isn't that bad. And then you have some patients with moderate arthritis that, you know, you see it on the x-ray and it's real, but they're miserable and debilitated. So for this person, I would say, you know, keep doing what you're doing. You may have to modify your activity in terms of, I'm assuming they're not running marathons anymore, but I would stay active, get the injections as long as they work. And then when they stop working or you're having pain, you know, more frequently, that's when I would consider a knee replacement.
Yeah, now the same person is then asking, how do you pick the right device? So again, I think there's kind of, if you could answer it in 2 parts, because I'm not sure if it's specific to the preceding question in regards to their specific situation, or if it's in general, how do you know what device to use for your knees? So for the second, maybe go into what devices are available and then how one is selected. I know that's a 3-part question there, Dr. Aberton.
Right. So I think, you know, at the end of the day, the most important thing is choosing the right surgeon, because I think, you know, if we talk about individual implants, there's several on the market, and you know, there's a handful that are used throughout the world. That are I would say the most tried and true, and then there's, you know, other newer companies that come out. But when you look at the data on them, they're relatively equivalent. So I think a well done knee is a well done knee, whether it's company A, B, or C. So I think you could, you know, bog yourself down in terms of, you know, this implant does this, and again, companies will say, you know, one thing versus the other. But at the end of the day, I think the most important thing is that you have a well-done knee replacement, and that should be the driving factor. You know, for me, I think most surgeons were like carpenters with a toolbox. So, you know, when you build a house, you don't ask the guy building your house what type of tools he's using. You just want to know based that he's built good houses before. And it's similar. So myself versus another surgeon who uses a different implant, I think the outcomes are comparable. It's just whatever you're comfortable with. You know, in terms of revisions, then it becomes different because you have to be comfortable. You know, obviously, if you're revising company A's implant, you're going to continue to use their implants because you're, you know, changing out parts, even if it's not what you use every day. So I don't know if that answers it, but I think it's less the implant and more technical.
Okay, no, that's a very good explanation and a very good way to maybe look at it. So thank you. Now our next question is regarding gel injections. So how long does the effect of gel injections last, and how can it be given? Is it just an injectable?
Well, so that's a great
question. How
question.
often can it be given?
Right. So the reality is so hyaluronic acid is like saying soda, and then there's Coke, Sprite, Pepsi. So there's different brands of the same thing. So Monovisc, which is the person's question, is one brand, and then there's many others. Again, similar to implants, we could argue one is better than the other, but at the end of the day, we want them to last 6 months. So if it lasts more than 6 months, you could repeat these every 6 months. Sometimes it lasts 8 months, a year. I just did a patient this morning who had it 4 years ago. But on average, we want it to last 6 months. You know, it's hard to predict who it's going to work in and who it's not going to work in, but in general, it works best in people under 65 with mild to moderate arthritis versus people with more severe arthritis and who are over 65, but it doesn't mean you can't use it. From my point of view, there's no downside to it. From the insurance point of view, it has become more of a challenge through the years, because when they look at studies, which they look at a little differently than you or I, because if you get 6 months of relief, I would argue that's successful. But from like an actuarial point of view, cost benefit point of view, some insurance companies are making it harder to get them. But in general, you could get them every 6 months. You could do it forever as long as they work. I do them, in the office as an injection. Some people do it with ultrasound guidance. Do I think that's necessary? No, but that's the alternative.
Okay, no, thank you. I think you brought up some good points there. So the next question, again, another one of our viewers was told by a knee surgeon that both knees are bone to bone and should be replaced, but rarely has pain, but has impacted ability upstairs. So this individual has to help themselves up the stairs with the arms. So A, is that common? And, is the recommendation when somebody is not having pain to still have a knee replacement?
Definitely. So again, I never tell patients they need a knee replacement, no matter how bad their x-rays look. I counsel patients, I talk to them, I'm very realistic and honest with them about, what to expect and why to do it. Again, it's hard to get the full picture with this person, but it sounds like they might not describe pain, but the fact that they have trouble going up and down the stairs, there's probably some limitation there. So ultimately it really depends on your quality of life. And so you could define that by pain, you could define it by limited mobility, avoiding doing things. So all those things, if you haven't tried any of the other conservative things, therapy, anti-inflammatories, injections, I would start with that first. And then if that helps, great. If it doesn't, then you have the decision to make. Sometimes depending on your age, health, I wouldn't do it to prevent problems down the road, but I have seen more than a handful of times in my practice someone who was waiting till it got really bad, and then all of a sudden now they have other medical problems which has precluded them from getting the knee replacement, and then that becomes a real problem and disappointment. So there's a lot to consider, but ultimately it should be about pain and quality of life.
Okay, thank you. So again, another question on the injections. Is there a limit on how long you can get injections?
No. So if I'm understanding the question correctly, meaning you could get the hyaluronic acid every 6 months for 10 years or indefinitely. Cortisone, we generally do every 4 to 6 months. And same thing, as long as it's working. I mean, the natural history generally is that with time, they won't work as well or last as long. Not because they stop working, it's just because over time your arthritis is likely going to progress and it won't be as effective. But as long as it works, you could do it for years and years.
So our next question is regarding knee supports. Do you think knee supports are helpful, and what role can they play, if any?
Yeah, so there's two kinds of knee supports. One is just like a compression sleeve, which I would say is the most common thing people buy in the pharmacy or online. They definitely can help. I don't know if they're needed per se, but there's no downside to them. Just the compression alone can help with swelling. Also, it gives people when there's something touching you, you're more aware of your joint. So just the tactile feel that you get makes you more aware and protective of your joint. So if you find that a knee sleeve helps, whether it's with sports or everyday life, there's no problem with that. Some people, you can get arthritis in just like the inside part of your knee or the outside part of your knee. And there are special braces, they're called unloader braces, where if you can see my hands like this. If your knee is wearing out like that, the brace will try and open up your joint. I mean, I'm exaggerating with my hands, but that's a special type of brace that can also help. So those are rarely, used or in specific instances, but can be helpful.
Okay, thank you. So now the next question is regarding muscle-sparing knee replacements. So if you can discuss them, what are they, and how effective they are as an option for folks?
Yeah, so like I quickly mentioned, most surgeons go through what's called your quadriceps tendon, which is your quadriceps is the muscle in the front of your leg and then becomes a tendon. Obviously, to do that, you're going through a healthy tendon to get into the knee, but that's sort of the gold standard way. What I do and what I think the question is a quadricep sparing, where you could go through the muscle on the inside part of your leg, and muscle heals better to muscle. It's less invasive. You can do it below the muscle as well. And the upside is, in the short term, the first 6 weeks, I think it's a little bit less painful. Again, I won't say no pain, but less painful. And you get better function of your quadriceps after the surgery in the first 6 weeks. At 3 to 6 months, I don't think there's a difference. So again, I think, generally speaking, you want somebody who does the operation, well in their hands, whatever that is, and has good results and a good track record. But the advantage of doing the quad sparing is it's less invasive and you're preserving normal anatomy.
Okay. So before you talked about physical therapy, so what kind of physical therapy is best? Is it needed before and after? So what kind of physical therapy is best before? And if you want and can, post-surgery as well.
Yeah, physical therapy before surgery is sometimes a double-edged sword, because most people are in a lot of pain. They have limited motion and mobility. So sometimes the therapy itself can be difficult because it will irritate the underlying arthritis. That being said, there can be some benefit to therapy in terms of trying to strengthen the muscles before surgery, trying to work on some of the soft tissues, work on your range of motion. But I generally don't have patients routinely go to therapy before the surgery. Part of what we have in the book that you get and at the classes will encourage you to do like some gentle motion on your own. And or if you're already working out and being active, that alone is, quote unquote therapy. You definitely need therapy after the procedure. Most of it has to be self-motivated therapy, like home exercises, which we teach you in the hospital, we teach you in the office. We do encourage people to go to outpatient therapy, usually for the first 6 weeks. And then depending on how you're doing, you either continue or at that point you could do most of it on your own. But it's really important because, there's two parts to success of the operation. One is the surgeon technical part, and then the other is compliance with therapy. And, we could argue you could do it on your own, the therapy, but most people need the guidance, motivation, and push of the therapist.
Okay. So with everything you've discussed today, is what you're saying applicable to the approach taken by the knee surgeons in the RWJ family, but not necessarily your facility? And are you affiliated with RWJ Hamilton?
So I'm not affiliated with RWJ Hamilton. I operate exclusively at Robert Wood Johnson, Somerset. Like I said, my offices are in Bridgewater and Warren, but I do my joint replacements at Somerset. One of the things that I think distinguishes us as a joint program is we don't tell the surgeons how to do the surgery, but we all sort of follow the same protocol in terms of the prehab, the hospital stay, post-op protocol, because by standardizing that, that has allowed us to decrease our length of stay, improve outcomes, decrease narcotic pain medication, decrease blood transfusion. So all of the, decrease infection rate, all of those other variables which are important are standardized here. So I can't speak for other places. I'm assuming a lot of other places, do the same thing, but that's what we do here.
Okay. Thank you. Well, does anybody have any other questions for Dr. Aberton before we close out before we close with the webinar? Okay. Well, if there are no other questions, again, thank you, Dr. Aberton, for a lot of informative information regarding knee replacement surgeries. If there are no other questions, oops, it looks like we just got one.
All right.
Hold on. Okay, one final question. We're waiting. She's typing. There we go. So do you have a recommendation on BMI pre-surgery?
That's a great question. BMI is a tough thing, I think, because it really depends on the patient's height, weight, size. So personally, I don't. Ideally, I'd like you to be under 40 BMI for me. Again, with some caveats there. The hospital would love everyone to be under 34. So, again, I think it really depends because, like a stocky, muscular man is, could have a high BMI, but you wouldn't think twice. So it's not, I don't make that decision in isolation, but I guess is the real answer. But under 40 is preferred, ideally under 34, 33. But it's not the only thing that I look at when I'm concerned about being overweight.
Okay, we still have we still have some more. One of the question is can you explain what BMI is for our audience, please?
Oh, so BMI is basically it stands for body mass index, and it's an imperfect way of identifying someone who is obese or overweight or morbidly obese. It's based on your height and weight, and there's a formula that basically, I don't know the formula, but there's just type in your height and your weight and it comes up with a BMI. And there's charts to stratify you into, overweight, obese, morbidly obese. I mean, you guys can't see me, but my BMI is, almost overweight. So it's an imperfect way of trying to stratify patients who are at higher risk for complications, because morbid obesity has been shown to increase your risk for complications, particularly in joint replacement with respect to infection, other things. So we try and optimize patients, but again, the challenge is losing weight is a hard thing even when you can exercise.
Okay, so I think we'll take our last question. A friend suggested stem cell as opposed to knee surgery. That's very interesting. So can you offer any information on this? What are the advantages and or disadvantages?
Yeah, that's a great question. So orthobiologics, which is stem cells, PRP, is definitely the future. There's really little basic science justification right now for it or any long-term studies. But basically, the idea is that you're taking these cells and you inject them into a joint or an area to try and create some type of healing process. it's sort of not anecdotal, but there are some studies that show it works. There's lots that show it doesn't make a difference. So there's no downside to it in terms of, it either works or it doesn't work. The biggest downside is economic, because typically insurance does not cover this, and this can cost several $1,000s depending on who or where you're going. And so if it doesn't work and you spent several $1,000s, it's an economic decision. But there's no downside. I don't believe it regrows cartilage in humans. At least at this point, that hasn't been proven. Could it help with pain relief? Yes. Is it helping by some different way of anti-inflammatory component? We don't know. So I would say that's the kitchen sink. So depending on your point of view and where you are, your age, other things, it's not unreasonable to try, but I'm not sure it's going to prevent the inevitable, of you needing a knee replacement if you're at that point.
Well, thank you very much for not only answering that question, but for once again providing us with so much information. And I hope we have armed our audience today with all the information that they need. So, so this is going to conclude today's webinar. Please remember that the opinions expressed here by our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referrals service at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset's joint surgery program, please visit our website at www.rwjbh.org/Somerset. Thank you again for joining us today, and have a great afternoon. Bye, everyone.